Okay.
Yes, now we are live.
Okay. So, shall I start?
Yes, yes.
Okay. A very warm greetings to respected dignitaries, organizers, all the delegates, and one and all who have assembled over here for this session. I'm Shreyas Sirwani, part of the organizing committee of Med-Invade 2021 conference, will be moderating today's session. Heartiest welcome to the 7th day of Med-Invade 2021 conference. I hope all the delegates are enjoying and learning a lot from this conference. I take a pleasure in sharing with you all that Squared Medicine and Research, in association with JP, our educational partner, has proudly commenced the series, continuing medical education series with eminent authors at Med-Invade 2021 conference, few days back. And today I will be taking it forward. Starting with today's session under the series entitled as Chronic Pancreatitis by our esteemed and eminent speaker of the day, Dr. Sriram Bhat sir. A little bit about sir. So Dr. Sriram Bhat sir, currently Professor, Head of Department Surgery at Kasturba Medical College, Mangalore, which is located in Karnataka, India. Also Honorary Surgeon, Government District, Venlock Hospital, Mangalore. Dr. Sriram Bhat sir has completed his MBBS and MS from KMC Mangalore, which is located in Karnataka, India. A very well-known surgeon, acclaimed surgical teacher in and outside the country, Dr. Sriram Bhat sir has a vast experience and spending for more than 2 decades now. He is a dedicated surgeon and performs all major and minor surgical procedures. He also performs laparoscopic and endoscopic procedures. Dr. Bhat is among the few of the surgeons in Mangalore to perform ABLA laser therapy for varicose veins. His contribution to medical literature by writing books has been immense. His book, SRB Manual of Surgery for MBBS and PG students, is well known among all the medical students. His other books, important titled as SRB Surgery for Nursing Students, JP Gold Standard Mini Atlas Surgical Series for Surgical Disease, has also been well acclaimed. He has also published innumerable number of research papers in reputed national and international journals. So far, he has attended many of the national and international conferences as faculty. Last but not the least, he is also the Vice President for Acute Critical Care Courses of India. Respected sir, it is our honor and privilege to have you over here with us today, and we all are very keen and delighted to learn from you. Before handing it over to sir, just a quick note for all our delegates that you can type your questions in the YouTube live chat box or Zoom chat box, and they will be addressed during end of the session. Also, post-event link will be posted in chat box and also in YouTube description at the end of the session. So make sure you fill the same to get eligible for the certificates. Now I shall be handing it over to you, sir. Thank you.
Thank you, Shreyas. Thank you, everybody. Good afternoon, all. Shreyas, shall I share the slide?
Yeah, yes, sir.
Okay. Is it slide is visible? Is it visible, Shreyas?
Yes, sir.
Yes, sir. Yes, sir. It is visible.
Okay. The topic for the day I have chosen is chronic pancreatitis. Reason being why it is chosen is it is a very distressing, real problematic, often challenging to surgeon to manage and to get a outcome, good outcome in relation to the quality of life and pain relief overall in a due course of the time, because this is a progressive disease. That's the reason I selected this topic, because a very, very common entity, especially in coastal Karnataka, in our place, probably all over world, actually, and very challenging condition to manage. And for students, postgraduates and undergraduates, it's a very common question, theory, practical, MCQs, Viva, in all different categories of assessment, it is being asked, being a very common interest. So I have selected this topic. So what is the definition of the chronic pancreatitis? These words are very, very important. I said it is a persistent. This word is very important. It is progressive. It never regresses. It's irreversible damage of the pancreas due to chronic inflammation. So why this inflammation? What sort of inflammation? Why it happens? All those things we will discuss in a due course of time. But this is the definition. These three words are very, very important. Remember, persistent, progressive, irreversible damage of the pancreas due to chronic inflammation. By and large, to have a gross idea to how it is being classified, even though it is not a real classification, these are exactly pathology occurs in different levels in pancreas: chronic relapsing pancreatitis, chronic non-calcifying pancreatitis without calcification. There is pancreatitis, chronic one, but without calcification. Calcifying pancreatitis more distressing. Calcification or stone formation in the duct, it will better than the calcification in the parenchyma. This is very, very difficult to manage. So this is at least we have got some options, especially either surgical intervention by and large, and often by endoscopic therapy to remove these stones. So there are some options for that, but this is very, very distressing to manage, and symptoms are much more severe in this type, or what is called as chronic parenchymal calcifying pancreatitis. So this slide is very, very important. This gives the correct exact meaning, or defines very well chronic pancreatitis. So what are the spectra of the disease in chronic pancreatitis? Early stages, there will be edema of pancreas, chronic inflammation. This point is again very, very important. Normal secretory function. So when I say normal function, there are two functions pancreas has got, all of you know: exocrine pancreatic function, where it secretes a lot of enzymes, digestive enzymes. So many enzymes are there, you know, that amylase, lipase, elastase, and so on. So many enzymes it is being released, and also endocrine function, especially insulin release and other hormone release. You know, all those endocrine cells, and so that is also these two functions, exocrine and endocrine functions, are normal in early stages. That point is very, very important, because everything eventually happens with the shortcoming of the exocrine and endocrine functions. So moderate early fibrosis and exocrine dysfunction. So as the disease progresses, there will be fibrosis and there will be dysfunction of the exocrine component. And severe case, severe fibrosis, both exocrine and endocrine dysfunction. In other words, in a patient with the chronic pancreatitis, when they develop a stage where diabetes is imminent, that means disease is late, disease is severe, and there is a severe both exocrine and endocrine dysfunction. That is what it says. And of course, eventually, is a part of this only. In different stages, it can happen. Different complications eventually can occur, including turning into certain extent through carcinoma of pancreas. So these are the complications: early, moderate, late complications. So this is the picture, just X-ray picture of a chronic calcifying pancreatitis. There are other severe. Naturally, these patients will have both exo and endocrine pancreatic dysfunction with the different ways of presentations. So what are the etiologies of the chronic pancreatitis? You know that acute pancreatitis, chronic pancreatitis. Acute is a totally different entity, even the organ is same. Wherein biliary tract disease and so many other causes are the uh, uh, for acute pancreatitis, and we go ahead with the Atlanta classification and so on. But this is totally different. Their main cause is alcohol. 80% of the chronic pancreatitis is alcohol. Of course, eventually, of course, biliary tract disease is the second cause, not that common. And malnutrition, diet is have an important role as a etiology for chronic pancreatitis. Hyperparathyroidism. Some people pancreatitis can occur, especially chronic one, as a familial or hereditary, that is through autosomal dominant trait. And idiopathic, where we don't know exactly, probably mutation in 20% of cases. Trauma, congenital anomalies, especially pancreatic edema, is very often they lead into the in due course of time chronic pancreatitis. Cystic fibrosis, all of you know that it is common in pediatric surgery age group, and so naturally lead on to the pancreatic dysfunction, pancreatitis, and so on. Autoimmune pancreatitis is a well-known pathological and clinical entity. Hyperlipidemia is again a known confirmed factor, and it is more common in males and common in Kerala. All of you know that, one of the state in Karnataka, in one state in India, where tapioca is a very common diet, where it is now confirmed that some sort of toxins induce the pancreatitis, and eventually they lead to chronic pancreatitis. And my place, Mangalore, is adjacent to the Kerala border, and so naturally we get a lot of chronic pancreatitis patients, which is probably we think is due to tapioca inducer. And you can see that here, large ductal stone here, multiple pancreaductal stones. All these things can happen. So it is not uncommon, but very, very common. What we see here, many times we get regularly such patients with the different distressing symptoms. So this is the classification. It is often asked as the short note, either in undergraduate or postgraduate. Tiger O classification. This is easy to remember. Tea is a toxic, again, alcohol, whatever I told, diet, tobacco, drugs. Tobacco, drug, hypercalcemia, lipidemia, lipoprotein lipase. Idiopathic, I is idiopathic. I already told all those causes. It is put it like in a clear way. And genetic mutation with the CFTR, SPINK, all those mutation traits, and autoimmune disease, Sjogren's syndrome, Crohn's disease also often associated with the pancreatitis, and severe acute ischemia of whatever the reason, recurrent one. And obstructive causes, I already told pancreatic edema, annular pancreas, stenotic papilla, due to obstruction of any cause, trauma, pancreatic stones, choledochocele, all of you know that choledochal cyst, one of the type is choledochocele, often causes pancreatitis. So this is the Tiger O classification, easier to remember, of course. Subcomponents you have to mention when it is asked as a short note or in the main question, whatever it is. This covers everything, all etiological causes in a simpler way. Tiger O classification is the one which is commonly used or easy to remember, this Tiger O risk factor classification. So what are the different theories and pathogenesis of chronic pancreatitis? There's the different theories. I'll just mention oxidative stress hypo. There are so many theories because you know that pancreas is a very, very complex organ in the body or in the abdomen. In specific, it is transversely located across right to left at the level of the L1 vertebra, and extends right, left in the retroperitoneum. And so it is anatomically also very organ structured in a different way, and functionally also exocrine, endocrine function, everything is there. So very, very complex organ which we come across in the abdomen. And so reactive byproducts of hepatic mixture function, oxidative active damage of pancreas through mainly reflux of the bile into the pancreatic duct, maybe due to alcohol, maybe due to toxins, whatever the etiology which I have mentioned in the earlier slide, which causes this oxidative stress hypothesis due to reflux. And toxic metabolic theory, again, alcohol is a direct toxic to the pancreatic cells, and it will cause all these problems: lipid accumulation, fatty degeneration, cell necrosis, and eventually in a due course of time, widespread fibrosis. I already told early, late, moderate, late, and complications, early fibrosis, severe fibrosis, extensive fibrosis, and so on. So that is what by toxic, because it is alcohol or whatever the drugs, whatever I have told in the classification, they are toxic to the pancreas cells as such. And stone and duct obstruction theory, because it's lithogenic, alcohol is lithogenic to the pancreatic juice, and so many other causes are there which pancreas stone can form, and usually they are radiopaque, quite hard stones, not soft stone like in what we see in the biliary tract or in the gallbladder. And it eventually causes ulceration, scarring, atrophy, fibrosis. So many pathological events will go on in due course of time because of this concept, because of different etiologies. So necrosis, fibrosis, stone, duct obstruction, toxic metabolite, all the things are the different way of exactly eventually. The important thing is atrophy. This is very, very important because once cells go for complete atrophy, its exocrine function is lost, its endocrine function is lost, pancreatic tissue gets thinned out or fibrotic, and that is what is called the burnt out effect. where everything's burnt out, tissues gone, destructed uh, with the chronic inflammation, fibrosis, and so on. So heavy prolonged alcohol is the most common cause of chronic pancreatitis. This point you would always remember. It is often asked as MCQ question, viva, theory, and so on. So you need to know why it happens, why it causes pain. There will be extensive calcification, ductal changes, endocrine and exocrine insufficiency. I already told because pancreas functionally exocrine and endocrine function. And anatomically, I have told head, neck, body, tail across the retroperitoneum in the upper abdomen, and often recurrent episodes acute pancreatitis for several years are seen in these patients. And some cofactors, all these things are genetically related. I'm not going to detail it. I already told cystic fibrotransmembrane regulator and serine SPINK, serine protease inhibitor, Kazal type 1 have been noted in alcoholic pancreatitis. All these things are the different cofactors which aggravate the eventual pathological events of the chronic pancreatitis. There is an entity called tropical pancreatitis, already told in Kerala, sometimes Africa or South America. As a dietary toxin, different diets in the different places can cause. In India, of course, tapioca is the common thing. Other than micronutrients, zinc, copper, all the deficiency can occur. Some genetic reasons, some ductal also probably causes for what is called as tropical pancreatitis. It is very common entity in the, especially in the developing countries. It too can occur in other countries also, depending on the what diet and other reasons, whatever I have told. Basically, diet induced tropical pancreatitis, not uncommon entity. Remember, you very regularly come across such patients in our day-to-day clinical or surgical practice. So, what are the stages of chronic pancreatitis? I already told there's a new staging classification for chronic pancreatitis, which we currently use it, even though it is same thing what I told earlier, which are put in different way: early, moderate, severe. Stage A is a chronic pancreatitis without complications, or pancreatitis without pancreatic insufficiency. I said normal secretory function, whether it is exocrine or endocrine function. Stage B is a chronic pancreatitis with the complication, but no pancreatic insufficiency. There are some complications, maybe pseudocyst formation, maybe pain, maybe other complications, but still pancreatic insufficiency is not occur. Patients have not developed diabetes. Exocrine insufficiency is not observed in this patient. And of course, EC is a chronic pancreatitis with the pancreatic insufficiency with or without complications. Here, insufficiency is the main factor in CGC. Here, no insufficiency, no complication. Here, complication, but no insufficiency. Here, insufficiency is the main factor in CGC. That is the A, B, C. C1 again, you know that endocrine insufficiency. C2 is exocrine insufficiency. C3 is both exocrine and endocrine insufficiency or with the complication. That is how being classified A, B, C, C1, C2, C3. So the current staging of the chronic pancreatitis actually, which I already told, early, moderate, late. So it is put in a different way as actually. So pathophysiology of complications, again same, due to secondary healing and fibrosis, deposition infiltrated pancreatic material in the duct. So duct get blocked many times in these patients because the duct function is inadequate. Duct often get dilated, and material, whatever secretion get uh, precipitated, infiltrated, and eventually acts as a nidus for stone formation, and often forms a big stone, especially in the head, and eventually in the other parts of the pancreatic duct, and multiple stones often. Usually they are radiopaque, they are hard, and duct get dilated in this patient. Normal duct diameter is, all of you know that, 3 millimeter, and here often get dilated 7 millimeter, 10 millimeter, often more than 10 millimeter, like a bowel it is. So on table many times you observe so much dilated pancreatic duct, and overexpression of the CTGF and TGF, you know, the transformer growth factor, B1, all those things also may stimulate extracellular matrix as such. So what are the clinical features? What we are researching different extensive etiology I would discuss. Remember Tiger Walk classification. Remember pathogenesis. Remember fibrosis, deficiency of function, means exocrine, endocrine. So eventually they lead into the diabetes mellitus. So there is an exactly for severe fibrosis, calcification. The two things very important you have to remember: progressive severe fibrosis and calcification, either in the parenchyma or in the duct. When it is in the duct, it becomes stones with the ductal dilatation. When it is parenchyma, it will multiple like nephrocalcin versus pancreatic calcification, like that. Nephropancreatic calcification. Nephrocalcin, no, not pancreatic calcification, the parenchymal pancreatic calcification. So, like nephrocalcinosis. So, that is the pathology you have to remember. Main feature is pain, pain, pain. Persistent pain in the epigastric region relates to back, and so much that they can't sleep, they can't concentrate on the work. So distressing pain, that's what it is, the main feature. That is what is the main indication for all sort of intervention, what we eventually advise to the patient. So there are two patterns of pain. Type A is a relapsing episodes lasting days to weeks with the pain-free intervals. They will have a repeated pain, then episodes of pain for a few days, weeks, then another few weeks there is no pain, absolutely pain-free. They are happy, they are normal with their work, everything, and eventually similar pain appears again in a same pattern for a few weeks again. So episodic pain, that is a type A, and type B is a prolonged, severe, unrelenting pain. Often it is often persisting pain. So usually, initially they will have a type A pain, and eventually, of course, in severe disease, they will have a type B pain. What it is, severe, unrelenting, and persistent, and of course, progressive. So this pain is due to irritation. All these things are the causes of the pain. Retropancreatic nerves are get irritated, duct dilated, or stretching occurs. There will be chronic inflammation, which is progressive. There's increased pressure in the ductal system and parenchyma both. You know that pancreatic parenchyma is covered by pancreatic pre-pancreatic fascia. So there is a fascia. So there is a pressure increases in the parenchyma also. There increases in the duct also. So increased pressure in the both system because of the pain also, along with that irritation of the retropancreatic nerves because of toxin, because of the leukemia, some proteins, and some growth factor release, all those things. So some toxins irritates the nerve gets attached, nerve gets irritated. So persistent pain. That's why they'll have back pain because retropancreatic nerve plexus are there. Greater pancreatic, lesser pancreatic, and least pancreatic nerves come there and supply the pancreas, and that gets actually irritated by the toxins. Pressure increases, irritation, so many things. Inflammation occurs, ischemia occurs, so many causes for pain. All these things. That's why they'll have persistent severe pain. There is often gradual decrease in pain. This is important thing. So everything eventually after everything is distracted completely. Pancreas get distracted completely because of the progressive disease as such. And this is called as pancreatic burnout effect. Completely it burnt. So extensive calcification will be there. Insufficient, of course, it is severe exocrine and endocrine insufficiency, but pain decreases in due course of not in every patient. In severe, long-lasting patients, it will go for a pancreatic burnout effect. The very eventual late feature of chronic pancreatitis burnout effect. So this is the usual thing what we see in a chronic pancreatitis patient. They won't leave. They'll always in this position, typical. And this is a triad of chronic pancreatitis. All of you know, calcification. They will have steatorrhea because you know that exocrine insufficiency present as a steatorrhea. There will be malnutrition, absorption is not there. You can look at them. They will be very they have lost weight significantly. They will skeleton. Protein deficiency there. So they're very typical. And diabetes mellitus, it suggests the endocrine insufficient. It's the triad of chronic pancreatitis, often asked in the MC question, viva, and so on. Remember, all of you know that exocrine dysfunction is the enzyme deficiency, diarrhea, asthenia, loss of fight, appetite, steatorrhea, naturally malabsorption. Endocrine dysfunction already told, diabetes, but brittle diabetes because of the concomitant glucagon insufficiency, which it makes compulsion to take insulin. And the important thing is, it is not the insulin requirement that says anyway it is there, but fluctuation in the diabetes. Morning it is 400, evening it is 80 blood sugar. Very fluctuation response in these patients. Very brittle. Diabetes is not under control. Diabetes is very brittle. We can't predict. Unpredictable diabetes. The meaning of the brittle, unpredictable. It is variable. So it is very variable. Every hour it may change. So they present in a different way. That is the problem with the pancreatitis. And if you see this brittle diabetes more very commonly if you do a total pancreatectomy. So most of the total pancreatectomy patient, if you remove entire pancreas for some reason, either for chronic pancreatitis or some malignancy, if it is so, then they develop what is called as brittle diabetes. That is the typical word which is used actually. So mass upper abdomen, occasionally they can focal mass above the umbilicus, tender, nodular, hard, felt on deep palpation, not moving the respiration, not mobile, resonant and percussion. You know that pancreas is in the retroperitoneum. In front there is a bowel mass. So naturally retroperitoneal mass will not move with the respiration. And they are on deep, felt on deep palpation, not on palpation, usual traditional palpation. And it will be firm or nodular, hard, often tender on deep palpation, and does not move with the respiration, no mobility, because naturally it is naturally because they are it is in the interperitoneal area, and because bowel is in front, there is it is resonant on percussion. So the very typical features are of any pancreatic mass. So, in additionally, what you think of in a patient with the chronic pancreatitis, history-wise earlier, and if you feel a mass, it still could be a chronic pancreatitis mass, maybe a small pseudocyst may be there, or focal mass formation, pancreatitis mass formation also may present as. But what is worried and what is yours, you should be suspicious is the as a complication turning into a carcinoma of the pancreas. If you feel a mass there, that also you have to suspect. So that also can present as a mass. Otherwise, pancreatitis itself can present like a focal mass. One of the common eventual pathological event which occurs in a certain percentage of the patients with chronic pancreatitis. So mass may be felt, may not, need not be always. Remember, it's not an essential thing. A certain percentage of patient mass able to feel it. So this is a very fancy mallet guy sign in right knee chest position. If left apical palpated, tenderness can be evoked in case of chronic pancreatitis. In this position, bowel loops are being shifted to the right, so as to have a direct palpation of the pancreas. So right knee chest position, you have to right side you have to turn, then bowel moves away, then you will be able to feel the body of the pancreas and tail of the pancreas properly, and tenderness can be felt. The very typical mallet guys, an old clinical sign where we didn't have much imaging methods other than X-ray. At that point of time, these signs were this sign was very relevant. So this is still it is will be able to elicit that in this position, if we able to be a deep palpation, will be able to elicit a tenderness, and this is typically how we elicit mallet guy sign, a typical of the chronic pancreatitis. Now, of course, with all these images in front of us, not very relevant, even though it is often asked in the MCQs. Why what they will ask what is mallet guy sign? You should know the sign is elicited in chronic pancreatitis. But you know, the typical of exactly will do that. So what are the complications of chronic pancreatitis? Now you know that stage A, B, C, and you know that early, moderate, severe, and you also know that uh, fibrosis, estrogen dysfunction, endocrine dysfunction. The varied it is stage A, B, C, it is varied, may be present, may not be present, but eventually with the complication. So very easy to remember: fibrosis, calcification, mild, severe, combination of either ductal parenchyma. If you imagine the pancreas and dysfunction, and we'll be able to evaluate and have a clear idea about the pancreas without any problem. This everything revolves on this calcification, parenchyma, duct, estrogen dysfunction, endocrine dysfunction, and of course anatomical, which part is not. Maybe head is mainly not, maybe body, but it usually head, then body, of course, tail, like that it goes in order. Because head is the pacemaker of the pancreas as such. So which area it is being involved, so how much estrogen dysfunction has occurred, how severe endocrine dysfunction is. So it is severe actually, it becomes stage C or late severe. So how many, what are complications which might have occurred in this patient? So that is how exactly we usually formulate or think or analyze when a patient comes with the chronic pancreatitis. Accordingly, we'll plan. So pseudocyst pancreas, very common. Pancreatic acid is quite common in the chronic pancreatitis when they go for relapse. Carcinoma pancreas, already told them around 10% of the chronic pancreatitis, often more, turn into carcinoma pancreas. Severe stricture due to edema and inflammation. Wordsworth syndrome it is called as. Wordsworth syndrome it is called as. Uh, Duodenal stenosis represented the gastric outlet obstruction. Remember, not uncommon. Often we get such patient and they'll have persistent vomiting. If you clinically examine, they'll have a gastric outlet obstruction with the dilated stomach, with the visible peristalsis, with the ausculto percussion test positive, with the succussion flash positive. And if you do any image, you know that greater curvature of the stomach is below the level of the umbilicus, rather down into the pelvis. That suggests that there is a gastric outlet obstruction. Invariably, naturally, when you think of chronic pancreatitis, it is due to duodenal stenosis, because head is mainly inward. When fibrosis occurs, it narrows the second part of the duodenum. So, which important is which they require surgery. You have to do gastrojejunostomy in these patients to treat the stenosis as such. Portal thrombosis, segmental portal hypertension can occur in this patient because very much related. Behind the neck, there is a portal vein, supramesenteric vein and sphenic vein joints, and portal vein in the middle of the neck of the behind the neck of the pancreas. And naturally, inflammation transmitted out there, thrombosis often can occur in a certain percentage of patients, then eventually it leads to the segmental portal hypertension. Peptic ulcer is a quite common association in the chronic pancreatitis. Maybe etiology is same, alcohol is the etiology. Pancreatic pleural effusion is a very known entity. Pancreatic ascites, pancreatic fistula. Splenic vein thrombosis the same way, because splenic vein is there behind the pancreas body and tail. Across it runs. So inflammation transmits and causes the splenic thrombosis. Same way like what portal vein thrombosis occurs. Same way splenic vein thrombosis can occur. Pancreatic enteric fistula, because of transmitted inflammation of the jejunum and may cause a enteric fistula. So these are the different complications which can occur in chronic pancreatitis, often asked in the MCQ, maybe asked as a theory question, enumerate complications of chronic pancreatitis, right, one by one, this one. To have some idea how exactly it happens, some reasoning you should be able to give, so that it is easier to understand why it happens. And if it is so, so you know now estrogen insufficiency, you know the endocrine insufficiency, you know that early fibrosis, late fibrosis, you know that there is calcification, and calcification, you know that in the parenchyma, in the duct. So that's what exactly happens. Just you can close your eyes and imagine what exactly happens. Then this is the only thing, everything revolves in this. You can always look into that and imagine what can happen very easy. And eventually, of course, have a investigation is important, because you have to find out how severe disease is, how severe insufficiency is, and what all complications which might have developed, especially which we are most of the time worried is carcinoma pancreas. If it is so, how we will go ahead with such patients. So you have to find out the anatomical, how much pancreas is distracted, and functionally both exocrine and endocrine, how much dysfunction has occurred, and of course, complications if it is so, what all complications, including suspicious carcinoma pancreas. So these things has to be evaluated. So you have to focus with these things, then based on different methods. Then so I have an idea how exactly what is the current, how exactly or what exactly is the current status of this chronic pancreatitis in a given patient as such. So if it is so, then you know how exactly to manage such patient. Of course, additional important thing is pain. Pain is the most important thing which most of us are worried to manage as such. Serum amylase is quite important in acute pancreatitis, but it's not very useful. It will be normal in many patients. Remember, doesn't say anything in chronic pancreatitis. Blood sugar, of course, very important. Of course, HbA1c, all the things are important. Liver function test, prothrombin time, also important. Ultrasound is a screening method, may not be, but screening is important here. We have to look at if there is a CBD dilatation, if there is a pancreatic status, more or less they'll be able to assess, not very in a detailed manner. At least they'll say pancreas is not normal, pancreas is disease. So basically, it is a screening method. Remember, any abdomen condition, ultrasound abdomen can be told as a screening method. So invariably a screening method, not the final evaluation method. Remember, not the final imaging method. So endosonography is a very useful tool, because it really gives a very close image of the pancreas across the duodenum and stomach, and gives the ductal status, gives the parenchymal status, gives a suspicious area, and also if there is suspicious area, you can do a needle aspiration of that area to confirm the turning into the carcinoma. So endoscopic needle aspiration is very useful investigation. It's very useful evaluating method. Of course, you need to do the other imaging first before doing that. You need to do the CT scan or MRI, then only go ahead to do the endosonography. Even though I put here, actually CT scan, MRI should come first, then you do the endosonography. Remember, CT scan should come first, then of course ERCP later. Of course, not CT scan you have to do first, some people may opt for MRI to see the duct, to see the pancreatic, see biliary system, everything to assess. It is often complementary to each other. Remember, CT scan mainly use a parenchyma, nodal status, peripancreatic tissues, portal vein will be assessed very well in CT scan, whereas MRI mainly assesses the biliary tree and pancreatic tree. So often it is complementary to each other. Once you do that, of course, then do the endosonography. ERCP is eventually when you do endotherapies, you do it ERCP, not initially to diagnose. Otherwise, if you're suspecting malignancy, so on, we can do, of course. ERP is so the chain of lake appearance, very ductal dilatation, chain of lake appearance. All these things are very typically can be assessed by a contrast CT scan now. It will be visible very clearly. So, but Viva or MCQ, they will ask, what is chain of lake appearance? The typical of the chronic pancreatitis picture in CT scan or ERCP, remember, chain of lake appearance. So MRCP already told it comes first actually, MRI, MRCP. Plain X-ray shows calcification because I said it mainly to the calcified stone, unlike gallstones. 90% of the gallstones are radiolucent, 10% are radiopaque, whereas renal stones, pancreatic stones, salivary gland stones, they're all most of the time radiopaque, remember. So unlike gallstones, same holds good here. Pancreatic stones are commonly radiopaque, remember. They're calcified naturally, that's why. Pancreatic secretory juice analysis is quite important. Pancreatorolor test. Fecal chymotrypsin elastase is a very sensitive investigation, but often these functional tests are difficult to do unless there's a proper biochemical laboratories are available. This is imaging and radiology reports are very well, we could be able to get endosonographies are available, but these things are not very well available, and analyze and studying takes time. So patient need to stay there. All those problems are there with this. So this is not that commonly done, but definitely they are very, very sensitive tests to find out the secretory function of the pancreas as such. So this is how exactly, this is the chart, how exactly we'll manage actually. So there are controversy, which one you will do first, which one should be done. It is individualized. You decide that one by individual patient. It's often difficult to say this is better, this is ideal, and so on. And also difficult to tell in the MCQ also and give an answer unless we got a patient in front of you. So you decide based on the patient presentation, as an individual patient will take, and then decide what exactly to do. But these are the things you have to evaluate. Evaluating the pancreatic duct, pancreatic parenchyma. Then of course evaluation of the pancreatic function. So duct, parenchyma, function, and adjacent structure. Of course, I said portal vein, phrenic vein, peripancreatic lymph nodes, liver, bowel, and other areas. So that is exactly will assess with the different CT, MRI, MRCP. Endosonography is very, very useful to assess properly pancreatic tissue. Of course, you can take a needle, already told aspiration to confirm or rule out malignancy as such. So this is exactly often plan, chart out to different investigations. Mainly do duct as a ERCP is very useful, remember. So CT scan is very reliable to those with calcific ductal stones, ductal stricture, dilatation, vasculature, fibrosis, CBD status, because CBD stricture can occur. It's very important. Often they present with after jaundice, remember. And it's very, very sensitive and high specificity also. So ERCP is very useful to dilatation stricture and ductal anatomy. And this is the ERCP staging, Cambridge grading of point in the ERCP. I'm not going to detail this, but often asked in the MCQs. Sometimes they may ask in the Viva. Mainly, you just remember ERCP grading. What is important is main pancreatic duct involvement, side branches. You know that pancreatic tubules are there. They branch from the side branches, and each side branches join into the duct. Now, these branches are very, very important when you do surgical intervention. You have to retain these branches to have a eventually to get the at least some percentage of functioning capacity of the retained still functioning pancreatic tissue as such. So main pancreatic duct again grade normal, equivocal, mild, moderate, severe based on the size, obstruction, filling, dilatation, regularity, content, and so on. Again, side branches less than 3, more than 3, 3 like that, abnormal. 3 millimeter is important. That's what I said, 3 millimeters is important. Here, large cavity, more than 10, like a bowel it will be. So that is how this is being classified ERCP wise chronic pancreatitis. You can see the stones here, multiple stone in the pancreatic duct. So many are there from head to toe down. See that across X-ray shows so nicely. And this is the parenchyma. See that? This is very, very difficult to manage such patients. This is at least easier. We can do a longitudinal pancreatitis, remove all these stones, and you'll be able to get away, get some sort of relief to the patient. This is very, very difficult unless you plan for a total pancreatectomy. Of course, it has got its own drawback, mortality, and of course, brittle diabetes and so on. Technically, not it's the demanding. This is technical. LPG is technically very easy actually, with the least mortality, patient to least mortality and morbidity. When you do a longitudinal pancreatic vaginostomy, shortly called as in short form, it is called LPJ. So these are how exactly the stones in a single patient. See that so many stones are this in the head, dark a body, and eventually it comes down like this, the tail. So it's common to be like this when a duct stones are so much. And CT scan, you can see that pancreatic tissues here, calcification, and so on. You can see the pseudoaneurysm here. Here, pseudoaneurysm is there in the pancreas. Again, feature of chronic pancreatitis here. So much. Small pseudocysts are there. Small pseudocysts are there. It's quite common. Multiple small pseudocysts are quite common in chronic pancreatitis, remember. And again, you can see the calcification. Entire thing is calcified here. See that? See that calcification? You can see the pancreas, calcified pancreas so much. Entire thing is calcified here. Chronic calcifying. It's very, very difficult to manage such patient. They will have some distressing pain actually. So dilated duct, you can see dilated duct here. See that the duct dilated here. You can see dilated duct here. So much dilated, thinned out. Parenchyma is very much thinned out. Usually long LPJ helps a lot in these patients. Some decoring also in this patient may be helpful, this patient. So ERCP, you can see that endoscopy here coming down, biliary tree, you can see that pancreatic duct, you can see that dilatation of pancreatic duct, you can see that. Something like China flake may not be typical, but you can see that dilated duct here. So ERCP is careful endoscope, then papilla, you can see the papilla, you can see the anomalies also. So you can see all this duct dilatation, biliary tract disease, biliary stones, aberrant junction, pancreatic ductal malignancy also. If there is a malignancy here, we will be able to identify. So you may be able to do a brush biopsy when you do a ERCP in a suspected area. There is additional advantage of the ERCP. So definitely it is complementary for other imaging. Not that you should not do. So initially always you will do a imaging like CT and MRI, then go ahead to the ERCP or endosonography. You will just select depending on the need as such. So sphincter of the manometry and biliary pancreatic sphincters to find out functional pressure area, intrabiliary system pressure. You can always assess pancreatic pressure also you can assess by this if manometry is available. So endosonography, I said, it's very, very useful. Currently, one of the important method of assessing the chronic pancreatitis with the complications and to find out complication, duct status and so on, structures, everything, parenchyma, all those things. Suspected malignancy also can be identified. So this is the different criteria for chronic pancreatitis, gland atrophy, hyperechoic foci, hyperstanding, cysts, lobularity, narrowing, dilatation, irregularity, calculi, side branch dilatation, I already told, hyperechoic walls. So all those things are ductal and parenchymal. Different findings will be able to identify. You can do a FNAC, you can collect fluid for assessment, and so many things you can do by doing endosonography. You can send it culture, cytology, fluid, everything. So in a set of where it is available currently in big gastro centers, it's available most of the major cities, and definitely it will be very, very useful in chronic pancreatitis. So this is the endosonography picture in a pancreatitis patient. So these are the other tests. I'm not going to detail that because function test is very difficult, even though they are gold standard to find out the facilities available. Assessment methodologies are rather cumbersome and difficult. So that's why otherwise it's very, very sensitive. Fecal electric is very, very sensitive to assess the pancreatic function, secretory function as such, especially exocrine function. So these things are very important, very sensitive, even though it is not commonly practiced. There is a point you have to remember. Already shown different plain X-rays of stones in duct and parenchyma, and these are the different tests used for the to see the tests for the function. I'm not going to detail it because it is not commonly done, but they are very, very sensitive. Remember, all these tests are very, very sensitive, but practicality is not that good. Of glucose, of course, naturally it is. So what is the now having discussed the investigation? So very simple investigation. Biochemical, not much except blood sugar. One. Two, second thing is imaging is very, very important. Ultrasound is only for screening. CT scan and MRCP takes over from the ultrasound. Even though even initial ultrasound image screening will do it. Then after that endosonography and ERCP comes. You decide depending on the situation of individual patient availability and depending on what exactly you want to look for, what exactly you want to get assess the pancreas or based on that you decide what exactly you are going to do after CT or MRI. CT and MRI are often complementary to each other, and of course functional tests is often even though they are very sensitive, the tests are not commonly done because of its own drawbacks as such. So having discussed about these things, how to evaluate, I already told evaluation of the parenchyma, evaluation of the duct, evaluation of the calcification, evaluation of the function. When I say function, exocrine pancreas and endocrine pancreas. So these things have exactly, of course, anatomical aspect of the diseased pancreas. These are the things you have tested by various imaging method and other things which are already discussed. How exactly? Having discussed about that, now we'll focus on the treatment aspect. Treatment is not that easy. That is the one which is mostly worried. It's a real morbid disease because you are treating a disease which is progressive, which is disease which is irreversible. Both the progression of the disease we can't prevent, and you can't reverse the disease already which has caused the damage. So these points are very, very important because you don't assure cure to the patient, don't assure will get a normal pancreas back to function to you. So definitely that assurance will not hold good in this patient. So aim is to control pain. This is important. Pain, pain, pain. If patient with a chronic pancreatitis, if the CT picture comes to you without much pain, don't intervene. That's very, very important because your surgery is more painful than this. So if there is no pain, you can always observe the patient. You've got other models of treatment. You can always postpone. Remember, improvement in malnutrition. Definitely, that is the aim again. Complications when it is there, you have to intervene. That's a big pseudocyst. Pseudoaneurysm is very important. We have to intervene usually by endotherapy or radiology interventions, vascular actually in interventions you can always do and control the pseudoaneurysm. If it persists, then you may have to go in and intervene surgically. Most of the time, radiologist can manage pseudoaneurysm currently. And choice of procedure. This is very, very important because morbidity and mortality both you have to take into account when you treat these patients surgically. Remember, because you are responsible for these two aspects during post-surgery period. So medical pancreatic enzymes intervention, ERCP stenting is the main thing. Surgical, of course, drainage and resection. The two different entities with different principles. I'm going to discuss that one. So conservative management, avoid the most important thing, avoid alcohol. They do that for a few months, then they say everything is okay, they start taking. That is the problem. They are not honest. That's the main problem with these patients. Eventually they'll die. Low fat, high protein, high carbohydrate, small and more frequent meals. That is very, very important. So they will have some sort of dyspepsia because of the pancreatitis, because of chronic pancreatitis. Let them take small frequent food, high carbohydrate, high protein, but low fat diet is very important. So you have to always advise this one what diet is suitable for them. Maybe you may have to take a dietitian's help for that. That will be more relevant in the current clinical practice. So for pain, analgesic, pancreatic normoselective, pain is very severe actually. Pancreatic enzyme replacement therapy is a very, very important. So relieve pain. Now you give these all those pancreatic enzymes, whatever available in the market, you give that so that it is not the only for function as exocrine drug. It also prevents the act as a feedback mechanism. It by feedback, it prevents the further secretion of the pancreatic exocrine enzymes, and so it gives rest to the pancreas. So idea of pancreatic enzyme replacement therapy is not just to replace the exocrine dysfunction or enzymes. It is also or otherwise mainly to prevent the secretion, whatever remained existing functioning pancreas through suppress the secretion of the pancreatic enzyme. Once you suppress, you are going to give rest to the pancreas. When there is a rest, healing is better. That is the idea. So that relieves the pain also. Function, when the less function, the pancreas will be less painful. There is a concept, they say less pressure will be there, so stretching will be less, secretion will be so less secretion reduces the pain. There is a concept. This is how exactly pancreatic enzyme replacement therapy also relieves the pain, other than giving a beneficial of the enzymes as such. So by feedback mechanism, it gives a rest to the pancreas. This is the point which is important. But it is beneficial. Studies say that when if you only in females lead to pancreatitis, small that is pancreatism, even though by practice, most of the clinicians give replacement therapy for lifelong or long time. Hopefully, acts as a placebo. They are benefited. Patients are scared to stop the drug. So they keep on eating the drug. They feel that it is better. Probably reason is to reduce the pain. So other drugs are antioxidant, amitriptyline for pain, octreotide, fluoxetine in acute phase, otherwise they won't give. And control of diabetes. Initially, oral hypoglycemics are started, and eventually they become insulin dependent invariably when there is a burnout effect or severe fibrosis, where severe endocrine insufficiency as such. Now, repeated acid traps for pancreatic acid, they get well. Many patients sometimes they need some sort of intervention or either endotherapy or occasionally surgical intervention. So steatorrhea can be controlled by proton pump inhibitors or oral lipase with the low fat diet. Low fat diet is very, very important. Remember, this is actually what advice. And pancreatic enzyme supplement will control steatorrhea actually. So medical minimum, treat addiction is important. That's alcohol. Pain relief, drugs, CT, here there is celiac block. Treat diabetes. Treat with the exocrine enzymes. I already told why you are giving. Maybe steatorrhea to control, and also of course pain, maybe replacement. It's a beneficial, different studies say different, but it is a standard method accepted as such, even though the results are variable by an individual patient as such. So nutrition is important. Again, I have told low fat, high protein diet, fat soluble vitamins and vitamin B12. Micronutrients are very, very useful. Remember, methionine, vitamin C, E, selenium, and medium chain triglycerides. All these are very, very important, very typical nutrition requirement for chronic pancreatitis patients. So this stuff is very, very important when you treat these patients conservatively. Every point is your advice in this patient. Diabetes control is very important. Pain relief, addictions is most important. Avoid alcohol, avoid alcohol. Don't take alcohol. It's the most important thing you have to advise this patient. Alcohol will cause a recurrence, problem, pain again, everything. 100% they have to stop alcohol. It's very important. Estrogen insufficiency and these diets. These are things should be you have to always concentrate, because many patients your treatment is mainly medical management. Only you select certain patients for intervention, either endo or eventually surgical intervention. So endoscopic therapy, main indicate pain relief, ductal stones, minor stricture, pseudocyst drainage. Now many remember many pseudocysts are drained by endoscopic therapy currently, not by open method like what we used to do 20 years back. Pancreatic acid is also mainly now many patients treat endoscopic therapy. Of course, pancreatic effusion, pancreatic fistula also by endoscope, pancreatic stenting they become better. So either that sphincterotomy, duct stone extraction by basket, different methods are by Dormia basket, stenting, stricture dilatation. ERW also can use because they are hard stones, calcium stones, so you can always break the stone. And all the six procedures can be done by endotherapy. Definitely quite useful. And a pseudocyst again can be treated by stenting across gastric wall through the gastroscopy or transpapillary stenting if pseudocyst is communicating. So less than 6 we can always wait. So these are the different method. You can do endoscopy, endotherapy you can do, or transgastric you can put a stent. It's very common thing. All of you might have seen that where endoscopy they do regularly. Or transpapillary you can do if a cyst is less than 6 centimeter. So treat the complication by endoscopic therapy, pancreatic stent displacement. These are the complications of course. Complications endoscopic therapy actually. Pancreatitis, stent displacement, occlusion, perforation, bleeding, sepsis, restenosis. Such patients require a eventual surgical intervention when endoscopic therapy causes all these complications. So advantage less invasive, can be repeated, less severe complications. It is actually a bridge therapy. You wait until they go for certain specific stage where you need to intervene surgically. Something like a bridge therapy. So they get benefit. Definitely it causes the pain relief and so on. Now, long-term benefits are less, and definite treatment is delayed is the problem. So disease is progressive. If it is not useful in a small duct is blocked or not functioning, this is of no use. So these are the disadvantages of this endotherapy, of course, but even initially it is definitely useful. So what are the indications of surgery? As a surgeon, this is the point I want to stress. There is certain percentage of patients, they need surgery, and which patient they need, we are going to intervene surgically as such. Persisting pains, the main is pain is the main indication. Severe malabsorption, we have to do some sort of a surgical intervention. First, when there is a malignant suspicion, especially when you do endosonography and needle aspiration, you have to do surgery. Multiple relapses, no drugs, no endotherapy is beneficial. Complications like cirrhosis, portal hypertension, biliary obstruction called a Wordsworth syndrome, and you have to do a hepatic duodenostomy, biliary diversion you have to do. Otherwise, they go for obstructive jaundice due to chronic pancreatitis and fibrosis, and CBD dilatation occurs called as Wordsworth syndrome. And pseudocyst, pancreatic dilatation, pancreatic ascites fistula, pancreatic stenosis, and these are the different indications I already told. Now, what are the surgeries? Pain is intractable. I said pancreatic stenosis, multiple strictures, head calcified calculi, pancreatitism, obstruction. Obstruction is another indication. Fibrotic, bile duct obstruction, duodenal obstruction, segment, what I already told. This will be classified obstructive. Ductal rupture, pseudocyst, fistula, pancreatic ascites, and cancer, malignancy when it occurs. These are the goals of surgery, remember. Cannot cure the disease. This is the point you have to remember. Don't ever assure cure to this patient. Indicated to palliate complication, decrease the rate of irreversible complications. So postpone the formation of complication, development of complication. This is the point you have to remember. You're never able to cure this disease. Don't ever assure that. This goal is very, very important to remember. And objectives of surgeries are pain relief when endotherapy failed, management of complication. Procedure selected is one which is less morbidity mortality, mainly quality of life. This is the most important thing. Your objective of surgery is quality of life, remember, not the cure for the disease. You will never able to cure the disease. Remember, there's a limitation. Remember, disease is irreversible, parenchymal ductal damage. So surgery cannot cure or reverse completely. Disease progression cannot be prevented or arrested by surgery. Remember, surgery is mainly to improve the quality of life. Risk of development cancer continues. You do a longitudinal pancreatitis, then after few years, still patient can develop cancer. Remember, complication of surgery are a drawback. This is the problems and limitations of surgery. Remember, so benefits of surgery are pain relief, obstruction relief, and remember, pacemaker, head of the pancreas are removed in certain surgical procedure like Frey's and Baker's procedure, and so their pain is relieved very well. Main thing is pain is relieved, and biliary obstruction, that if you do bypass, that is also relieved. So pain and obstruction relief surgery is very, very useful. Remember. So what are the principles? One is duct decompression, drainage, like along with the macrogynostomy. So normal diameter 4 millimeter in the head, 3 in the body, 2 in the tail. More than 7 millimeters an indication for surgery, even though sometimes lesser than even 5 millimeters we can operate because pain is so severe, nothing is helps, no endotherapy, more drug help, then you may have to do surgery. And the recurrence of symptoms. After 5 years, 50% recurrence can occur in many procedures. Remember, you're not assured because disease progresses. Progression of disease pathology, you don't have any control on that. Does not give a complete cure. Chance of meltdown is still there. Now, advantages are technically easier, less mortality. Remember, this is the one. This is definitely cures pain, removes the malignancy focus, remove the disease tissue. They're cured completely. But the problem is mortality is more than around or more than 10%, and brittle diabetes. If you do this one, they are cured. I have done few patients with the total pancreatectomy where patient insisted. They have done well, young patient actually, and after surgery, female patient, she got a brittle diabetes. Of course, she has been assessing herself for insulin, and she married. She got two children actually. So they do well because she's very happy because no pain, and she's taking pancreatic enzyme supplement, and she's taking insulin, and she's very happy because nutrition is absolute. She gained weight more than 20 kg of the existing earlier. and they do well. But only thing is mortality on table patient may die, post-operatively lot of sepsis can occur. So many things are there. Of course, then it is through. So head does consider the pacemaker pancreas. Remember, this is the MCQ question. Pacemaker of the pancreas is the head. Remember, everything begins there. So pancreas heavy post procedure is the other option. Remember, disease mainly starts in the head. It's head which causes the problem. So instead of removing the body and tail, remove the so avoid brittle diabetes. So even though less functioning body and pancreas, so it will patient will be diabetic, insulin they will take, but the brittleness of the diabetes is will not occur. So brittle diabetes is prevented. Only they'll have diabetes which is insulin dependent. If you retain body and tail, that's the concept. In such a patient, you can remove the head like a Whipple's operation. When you do that, body and tail is retained. So it gives a better diabetes control in this patient. That is another option, Whipple's operation. And remember, head of the carcinoma is common in the head of the pancreas in a patient with chronic pancreatitis. So that is also, it reduces the incidence of developing carcinoma pancreas, even though do can occur in the body and tail, but it's more common in the head, remember. People which are having relatively normal body and tail, especially when body and tail is normal, where mainly disease occurs in the head, then this is definitely a better option to retaining body and tail. When disease is limited to tail and body is not common, distal pancreatomy with the this splenectomy can be done with the pancreatitis. Now, it's technically difficult, all these things. High surgical mortality for total pancreatomy, estrogen deficiency will be there. For brittle diabetes, already told. So combined resection diagnostic procedure is quite useful, actually, very good procedure. Both to do a part of the head you dissect and do a drainage procedure. So surgeries are, I'm just to go through that. Partington Russell operation, it's the most common procedure done. Longitudinal pancreatitis, where you retain the spleen. Unlike good old traditional old procedure is a Pusto's operation, where you remove the spleen. Here we don't remove the spleen. So Pusto's same thing, but the Pusto is to remove the spleen. So that is not done now. So what we do, what is done commonly is the Partington Russell operation, not Pusto's operation. Remember, Pusto's operation was the guideline to do all these procedure, initial procedure actually. Now currently done is a Partington Russell operation, longitudinal pancreatitis, other is called LPJ. So after excision of the, often you will excise the peripancreatic ductal tissue, and so that head is removed. Disease head is removed partly. So only superficial part. This is called phrase procedure. This has got a very good pain relief. So they do very well. And M more is a Baker's procedure, where head is removed and transected neck. So that you cannot do the anastomosis for the retained head and retained and body and tail separately. So difference between the phrase and Baker is phrase you remove less tissue of the head, whereas a Baker you remove more tissue. But the complications like injury to the portal vein, injury to the biliary duct is more common. It is a more demanding procedure. Technical skill is required. Baker, whereas phrase is much more easier because you are removing only superficial part of the head. So the otherwise it's the extended fray actually. Baker's is extended fray procedure. But because you're removing the many part of the head, so their pain relief is very good with the Baker and face procedure. So this is the final thing. Definitely, it removes the malignancy focus. It also removes the entire pancreas. Pain is relieved. Only thing is brittle diabetes. Of course, mortality you have to explain to the patient. Possibility. Triple is another option. So triple anastomosis if there is a obstruction, duodenal obstruction and biliary obstruction, then you can do a hepatogenostomy, gastrogenostomy, jejunogenostomy called as triple anastomosis. So I'll just show the diagrams of one by one. I don't waste time. Already it is 4. Longitude is the LPJ. See that? Just to open and do that. This is the Partington Russell operation. Spleen is retained. See, this is the stone here. Duct is there. This is a stomach. This is the exactly the anastomosis. See the anastomosis being done. Anticolic anastomosis. See the colon here. This is the anastomosis done here. LPJ done here. JJ also done here. This is the duct. See that big duct actually. And Pusto's not done now. Spleen is removed. It's the good old procedure which whether on this only all those newer procedures come. Let's say Pusto, word Pusto is very popular in surgical site, even though it is not commonly done. So phrase is a remove everything, open widely, remove the superficial part of the head, and so that pain relief is very good. This is called phrase operation. Decoring of the head also done. And Baker's is you remove more head with the transection of the neck. So which more aggressive decoring is done, like a phrase it is. There is also very good pain relief with this. And again, this is the phrase procedure being done here. And do only distal disease if there is not common. Remove the spleen and distal pancreas and do a pancreatitis like this. Not very commonly done procedure. Often, mostly it is very uncommon technique done, but mentioned in the book actually. There are so many procedures mentioned in the book, not necessary. Please remember these three things, these few procedures in your. What you have to remember is Partington Rochelle longitudinal pancreatitis. Partington Rochelle LPJ. That is the one which is most commonly done as a drainage procedure. The section is total pancreatectomy, of course, with, if possible, islet cell autotransplantation to reduce the diabetes problem as such. So this is the total pancreatectomy done for the pancreatitis. So pancreatic pleural effusion is another common complication. You can always place ICT, then of course you have to do a endotherapy and place a pancreatic stent actually. Bile duct stricture, I said Wordsworth syndrome. This is the MC question. Again, you have to do hepatitis. See that in the pancreatic patient, this is what exactly happened. Do a hepatic genostomy. Prove it that you have to do hepatitis. Surgery is required in this patient. During again, you have to do a GJ, gastrojejunectomy, bypass or pancreatitis. Gastrojejunectomy. You do that. You have to do a gastrojejunectomy. GJ you have to do when there's a duodenal stenosis. Remember, pancreatic ascites. This is disruption between the stricture. Pseudocyst may rupture in a communicating pseudocyst. You can observe nutrition, percutaneous drainage, all octreotide is very useful in pancreatic ascites. Remember, surgical correction, duct obstruction, stenting you can do. Sometimes you do a surgery, of course, LPJ or head coring, but most of the time endotherapy and medicines, aspiration, octreotide, nutrition, they do well by conservative method. Splenic vein thrombosis, because of the respiratory portal hypertension, treat usually conservatively. There is a gastric was treated. Bleeding is not a common in this patient. Clinical embolization, splenectomy is not common now. Embol is sufficient in this patient if there is a problem. Most of the time, conservative treatment is sufficient. Pancreatic stones, I already told, calculate innovation with the structures, can be approached endoscopically surgically. Endoscopy combined with EW improves the clearance. EW is very useful because of the hard stones. Anywhere stones are hard, EW is quite useful. Remember, like in kidney stones. Kidney stones are mostly red opaque. Surgical treatment includes removal at time duct compression. You can do LPJ definitely, same like what I have shown. Recession in the focal mass or small peripheral duct you have to do. See that? These are the stones there. See that? CT shows the multiple stones here. Same stones are removed here during LPJ. And the stricture, again, you have to do LPJ. Stenting can be useful. Non-surgically prepared by a patient, of course, eventually requires surgery. Dilated pancreatic duct, again, non-dilated pancreatic. These are the things points you have to remember when you do surgery. Remember, focal mass present or not. What surgery you will do is important. Drainage, resection, that's important. Resection is the best, but demanding technically. Complications are more. Drainage is initially it is ideal because no less morbidity, no mortality. So focal mass, I already told, it is identified by CT and MRI. Endosonography you have to do because to rule out malignancy. It could be malignant and requires if it is not malignant, you have to request a decoring, either Fraser procedure or Baker's procedure. If it's suspected malignancy, then you have to do a Whipple's operation or sometimes total pancreatectomy as such. Focal mass in the head is very common. Resection, Baker procedure phase, if it is not malignancy, bilateral preserving. Focal mass body and tail not common, but can occur. So distal resection and dual procedure you have to do. No focal mass, that like a decompression resection without focal mass. Non-dilated pancreatic duct decompression resection. So pseudoaneurysm already told. CT angiogram and intervention, embolizations and surgeries, even though we used to do earlier quite commonly, now it is rare. Unless there is a complication occurs by embolization, then only we do surgery. Otherwise, most of the time intervention helps, or at least initial embolization, then eventual surgery definitely helps because it shrinks in size. Your surgical intervention will be difficult. There is high mortality for surgery also. So that's why treatment is most of the time interventional radiology by embolization. It is quite common complication. Remember, we see very regularly now pancreatic pseudoaneurysm, especially splenic vessel aneurysm occurs. So chronic pancreatitis, it remains an enigmatic process of uncertain pathogenesis. I said uncertain pathogenesis. There is a fibrosis, there is calcification, there is both fibrosis mainly in the parenchyma, of course, sometimes calcification, stone formation of in the duct. Then, of course, functionally, exocrine insufficiency, endocrine insufficiency, both are really problematic. And of course, it also creates a focus for malignant transformation, at least more than 10 to 20% of patients. That is also real dangerous. and it's got an unpredictable clinical course. It is progressive, it is irreversible, and that's why it is very, very difficult to treat. So treatment is always unclear, even though you've got so much treatment modalities, we are not sure what benefits to which patient, how far it benefits, whether by all these procedures and interventions or treatment, whether you're really going to prevent in due course of time, which may happen what is called as complications of chronic pancreatitis. Very, very difficult to prevent or avoid in spite of all these intervention, therapies, modalities, whatever I have discussed until now. So Theodore Cocker called the pancreas a mischief maker of the abdomen. Definitely the most dangerous organ in the abdomen. Remember, liver is okay, amenable, but pancreas is really distressing. Normal pancreas, if you've seen somebody's open the abdomen, if you see the pancreas, very soft, very easily can palpate, looks very nice, so beautiful, but really dangerous. That is why some surgeons have stronger language to describe this organ, but decorum demand that such language before for such a so it's very difficult to assess this patient time. That is why Moynihan called pancreas abdominal tiger. You may love to see the abdominal tiger from distant because quietly sits. It's very nice to see tiger, but in danger tiger when you jump on you, really dangerous. Most dangerous organ to surgeon and treat when it creates disease, when it has got a disease, either malignancy, pancreatitis, acute or chronic. That's why it is called as abdominal tiger. What Moynihan told more than 100 years ago still holds good, especially when you consider pancreatitis, a disease as such of the pancreas. So pancreatitis, acute, chronic. Acute, I am not going to deal. Chronic, briefly, I have told. There is a lot to discuss about that. Remember, it is progressive. Remember, it is irreversible. And remember, you can't prevent its progression by any method. You can only treat their symptoms, and at least you can postpone the complications. What you are achieving is postponing the complication. Remember pathology, exocrine, endocrine functionally, parenchyma, duct, and anatomically. And remember burnout effect and assess accordingly. Main assessment is diabetes assessment that says that disease is severe. That says that disease is C, stage A, B, C, stage. And also remember assess duct parenchyma, exocrine function as such. There are so many tests are there, exocrine function, that's very difficult to do tests, difficult, not amenable, practicable. So we are not using usually imaging CT, MRI, MRCP, then endosonography, and of course ERCP when it is needed. Of course, treatment is initially always conservative. Severe pain, go for endotherapy. Then of course, eventually lead on to the surgery. Surgical intervention indications are already pain. Second indication is obstruction, whatever that, maybe CBD, maybe duodenum, maybe portal vein thrombosis, maybe splenic vein thrombosis when required. Not every patient, remember. And if it is so, treatment is drainage and resection. Resection is ideal but demanding. It is technically because a lot of fibrosis is there, unlike in a normal pancreas, and bleeds a lot actually. Additions are very common, and total pancreatitis is the choice in this patient. They land with the brittle diabetes, but you are removing the focus of the malignancy. You are removing the entire disease, so they are absolutely pain-free for their eventual life. So there is no gland, so no disease. So that is the resection. But commonly done with no mortality, less morbidity, is the drainage procedure. Longitudinal pancreatinostomy, parting rochelle is the commonly done procedure. But this drainage with the decoding is the better one because we are removing the pacemaker or focus, head focus part of it, so that pain relief is better. Either Frey or Bager, which is more aggressive removal of the head actually. So Bager's, Frey's, parting rochelle. So the three procedures as a drainage procedure commonly done. Fustos, even though commonly, popularly considered, is the old procedure, which is a pillar to get all these newer procedure, which is not commonly done now because where they remove the spleen, we don't remove the spleen currently, you retain the spleen actually. So Partin Rochelle, LPJ, Frey's procedure, and Baker's procedure. So the three drainage procedure. Resection is total pancreatectomy, and sometimes repulse if disease is mainly in the head, you can retain body and tail. So these are the different surgical interventions which you do. There are so many procedures which are not necessary for you. Remember, 3 of the drainage procedure, 2 of the resection procedure, that is total pancreas and repulse procedure. If you remember, that much is sufficient. Of course, complications you have to remember accordingly, you have to treat. So it's a very vast subject, very distressing subject, not a palatable disease, to treat by a surgeon as such. So that's about in briefly about chronic pancreatitis. The main question for UGs and PGs, and a lot of MCQs will be asked. And over that, in your clinical practice, whether it's MBBS, we do get a lot of chronic pancreatitis patients. We should have at least a gross idea where to send, what are things to be needed. Actually, to explain the patient, these are the things, even though you are not going to treat. These are the things, this is exact, it's not easy disease, it's a difficult disease. These are the problems with the disease you have to tell always. So it's what exactly in brief about chronic pancreatitis. I hope you understood whatever I'm told. Thank you very much. Thank you, Shreyas, and thank you everybody. Thank you, Anurina. So thank you, students, and everybody who have attended. Thank you very much. Over to Shreyas. I will.
Thank you so much, sir. That was such an amazing and insightful session, and I literally loved it because of that clinical images which you added and surgical images, X-ray findings, CT scan findings. It was really a cakewalk for us. So moving on to Q&A session, sir, can we proceed with that?
Yeah, I will go to the proceed. How to unshare this one? I will unshare the slide.
Yeah, sir.
It's already unshared.
Unshared.
Yes, sir. It's a small request. We need to play the JAYPEE publishers PPT. So we can take questions from the background. Can we play the PPT?
Which one PPT? What PPT?
JAYPEE publishers PPT, sir. Promotion PPT.
Okay. Yeah, okay. Well, how? I didn't understand your question. What exactly you wanted?
Like for every session, we will play the JAYPEE publishers PPT, sir.
Okay.
Like clinical books and the design of one. So
Okay.
you can take questions from the background. Just we will play the PPT, sir. Like your question and answer session will go on. Just we will play the PPT. That's it.
Okay. Okay. No problem. No problem. Okay. I will. How to unshare my this one? You want to remove this PPT, no?
Yes, sir. I have already removed, sir. I will share.
Okay. Okay.
Shreyas, please continue with questions.
Okay.
Okay, sir. So first question is life expectancy of chronic pancreatitis patients after surgery.
It is not the surgery which kills the patient, actually. The disease which kills the patient, that is individualized. If there is how progress disease, how bad disease is decide the life expectancy of the patient. One. Second thing is malignant transformation is really worse because malignancy in these patients definitely much more severe than the adenocarcinoma occurring in the head of the pancreas. As such, carcinoma of the pancreas is very aggressive. But in the pancreatitis backup, it is very difficult to manage. So they do have a difficult outcome. Otherwise, in a patient with the duct dilatation, only much more duct dilatation, their life expectancy is good. When there is a more parenchymal classification or parenchymal disease, I was told very clearly, I told parenchyma duct. If there is a more parenchymal fibrosis and parenchymal disease, their life expectancy is not good. If there is a more duct pathology with the stones, duct dilatation, their life expectancy is good. So another thing which decides the life expectancy is the transformation into the malignancy. So it is the parenchymal disease which gives the poor life expectancy, more severe parenchymal disease than the duct, and of course malignant transformation. So the two deciding factors about the life expectancy. If there is severe parenchymal disease, they live for only few years. If there is a malignancy in this patient, of course, you can say a few months, not more than that. So that is the answer probably.
Thank you so much, sir. So our second question from the delegate is how to manage the pancreatic leak after Whipple's procedure.
How to manage pancreatic leak after
pancreatic leak.
Pancreatic leak after Whipple procedure is very distressing. So we have to decide how leak has occurred, whether it is complete disruption of your anastomosis or partial disruption. Now, complete disruption, it's very difficult to manage, but you have to go in and do remove the remaining pancreas and go ahead with the total pancreatic because its own mortality. But it got as such a complete disruption, it got a high mortality. It is not a palatable one which surgeons expect. Partial disruption, so you have to evaluate this patient by the MRCP and find out whether it is partial or complete. partial disruption, you got a drain there, drain leaks, and slowly it eventually forms a fistula and a pancreatic fistula, which is a controlled one. Once you achieve a controlled pancreatic fistula with a partial disruption, most of the time they may settle in the due course of my time, maybe in a few months, for 6 to 12 weeks. So we observe such a patient. Complete disruption is really dangerous. It has got a very high mortality. You have to intervene and go ahead and remove the body and tail, and to save the life of the patient. Of course, surgery itself is got high mortality, even though technically extend in a patient who have done we have done Whipple's to remove the body and tail of the pancreas with the spleen in this patient is not a difficult technical job. Within half an hour to 1 hour, you can remove the body and tail without any problem. But because once there is a complete disruption, patient is having sepsis, pancreatic fluid everywhere, and that hemodynamically they are really unstable, that kills the patient. So that is the problem with these patients. So it is a different story as such. Maybe because also so many grading is there. I'm not going to discuss that at a higher level for post graduation actually. So at least remember, complete and partial disruption you have to assess whether to intervene immediately or create a fistula, controlled fistula in due course, and then plan what accordingly patient survives. That is what that I meant.
That was such a beautiful answer, sir. Thank you so much, sir. So our next question is, what are the chances of post-operative pancreatic fistula following pancreogastrotomy and pancreojejunectomy?
Pancreaticogastrostomy, pancreojejunectomy, you are connecting to get the function, because when you do technically pancreaticogastrostomy is easier because pancreas gets into the stomach, but only thing you pancreatic juice get into that because hydrochloric acid all those neutralized, so you will not have any pancreatic enzyme function. Whereas pancreaticojejunostomy, if it leaks, it is a problematic. But once you do the pancreaticojejunostomy, your function is retained. Actually, take-up is better. Eventual outcome will be better. The lot of studies have gone maybe 10, 15 years back. There are a lot of studies have come in relation to the pancreatic gastrostomy. Eventually, even we were doing pancreatic jejunostomy initially, so go to the pancreatic gastrostomy for a few years. Then we came back to the pancreatic jejunostomy now. Most of us are again doing pancreatic jejunostomy, not gastrostomy, even though I have done pancreatic gastrostomy in many patients a few years back. Now we are currently, most of us are doing pancreatic jejunostomy. So it's a debate which is better, which is not better. Technically, if you are not very well versed with your pancreatic jejunostomy, then you will go for a simpler version pancreatic gastrostomy. Especially we'll say duct is very small, it is very friable tissue, pancreas is very friable, not a texture is inadequate. Then you feel that you are going to leak by jejunal anastomosis. Then you may dunk this pancreatic stump into the stomach and safeguard your interest. That is the only indication for pancreatic gastrostomy currently, because a lot of studies have gone. Maybe 10, 15 years back, a lot of people are doing pancreatic gastrostomy. Then eventually they come back to the pancreatic jejunostomy. Of course, currently available suture material, stents, technique, energy source, everything. Even leak stages come. If you are very precise, slow, meticulous, without any hurry. Surgery in olden days, surgery you have to do very hurry. You put a time and do it. It's nothing like that. In a pancreatic surgery, you do it slowly, take your time, be relaxed, and do a proper anastomosis. Make sure that your anastomosis is perfect. Then it will not leak. So that's why you take decision. Pancreatic jejunostomy is always preferred one. As far as me is considered, I prefer pancreatic. I have done both. But when you will do pancreatic gastrostomy, if duct is small, parenchyma is now very friable, your suturing will not take up even though you are using polypropylene, then I will dunk the stump into the stomach and I said, safeguard my and patient's interest. Probably that is the reason. Otherwise, pancreatic jejunostomy is not a bad thing to do if you are skilled, if you got a patience, take your own time, no be in a hurry. Surgery is not a hurried procedure at all, current concept. So naturally, shouldn't be a problem, I feel. Stress.
Wow, sir. Yeah, that was such an amazing thing to know about. Thank you so much, sir. Moving ahead with next question. Why are NSAIDs avoided in chronic pancreatitis pain management?
Why are? I didn't get the question, Face.
NSAIDs. Why are NSAIDs, non-steroidal anti-inflammatory drugs,
Oh,
avoided in?
non-steroidal anti-inflammatory drugs are avoided in chronic pancreatitis.
Yes, sir.
Reason is uh, it is said that NSAID itself can precipitate the acute episode of the pancreatitis one, and there is always an association of the peptic ulcer in these patients that may get aggravated. But NSAID itself is it provocates the pancreas to some level of whatever that I will say that whatever the transmembrane growth factor that is everything. There are so many factors are there. It's difficult to remember. To that factors, it is something like act as a toxin to the. I'll put it like that. Drugs and toxin. I put tiger classification. I put no in the T category toxins. So this drug acts as toxin to the pancreas. So naturally, avoid toxin. As such, there is a pancreatitis. So avoid that. That's the reason. So it somewhere stimulates by whatever the factors methodology I have told with whatever the biochemical events. That's the reason. That probably answers your question.
That was something. Yeah, so that was something new to know. Thank you so much, sir. So moving ahead with next question, is exercise useful or advisable in mild cases of pancreatitis as it could help in fat reduction, weight loss?
Definitely, it is not a contraindication. Nobody said that it's a contraindication. If you are fit to do the exercise, you definitely can do that. Now, what prevents from the individual to do exercise is the pain. If there is a fever pain, nobody will go ahead with the pain. Nobody will exercise. That's a very natural thing. If somebody is having severe pain with the picture which I have shown, like bending forward, you can't motivate him for exercise. He will shout at you. You don't be worried about exercise at that point of time. If he is pain free, exercise will not be a worry him to, or somebody will not question why he is doing exercise. Exercise is not a contraindication for pancreatitis unless there is severe pain. If mild, he said, somebody said mild. Question is mild, pain will be less only. Naturally, exercise is definitely can go ahead with that. I don't think it should be come into the picture at all.
Thank you, sir. Moving ahead with the next question, it is also mine. Is pancreatic transplant feasible? Practically, sir, what are the indications if it's feasible? How we can go about doing that?
Pancreatic transplant, yeah, feasibility, one thing you have to think. Second thing is what type of transplantation you are going to do, whether the exocrine and endocrine together. And third thing is where exactly you want to go. You have to go, whether you are getting only islet. So it's put islet cell transplantation. Islet cell transplantation, if you are doing in a different way, you are infuse islet cells into the patient and do that. You have to segregate the islet cells from the pancreatic tissue and so on. Otherwise, you are doing a clear-cut pancreatic tissue transplanted to the bladder or somewhere in the pelvis, or depending on the situation. So, what type of transplantation you are going to do, and only islet cell transplantation you are going to do. So that decision usually made by the transplant team actually, and take up also you have to plan. And it's a diabetes status also has to be, naturally they are diabetic. That's why you give the transplantation to avoid that or reduce the severity of the diabetes. And which type will be decided in eventually due course of time actually. So, but in these patients, in patient like this, islet transplantation is better. But how far it is beyond my level to discuss actually. Those who are transplant surgeons or those are, there are now transplant surgeons are classified in Western countries. They only do liver transplant, only those do kidney transplant, only those do bowel pancreatic transplants. So such specified teams decide what type of transplantation you are going to do, whether it is a hardcore pancreatic tissue transplant or islet cell segregation and transplantation. That's what my limited knowledge of transplantation that probably answers your question.
Yes, so that was such a wonderful answer. Thank you so much, sir. So moving ahead with the next question, sir, how we can go about studying surgery in our final years for focusing our post-graduation exam and also our university exams. If you could throw some light on same, that would be great.
Final year exam, you got three components. You know that theory, you got a practical point. In that practical clinical cases are the long case, short case. Then of course you got X-ray. Some places slides are there. You got a specimen. You got upward surgery. You got instruments. So accordingly, you have to devise yourself in the final year and go through theory also. You have to, because you got 15 short notes in many universities, the 2 main questions. So there is a wide range of questions with the 2 papers, and wide range of subject is covered in surgery actually. So you need to know many question papers in different universities. I have gone through that. They do ask in a minute detail. So this is not important. This is important. Very difficult to segregate. What is there in the syllabus? They have to know. That is because we can't say this question cannot be asked, this question should not be asked. There's nothing like that. So what is syllabus should be answered. So they should know at least basic. What I actually suggest them is make a note which is difficult. Like electrolyte topic is very difficult to remember. Even now for me it is difficult. If I take a class on electrolyte, I can't just jump in. If I take a class on chronic pancreatitis, I can talk anywhere, because I have operated many pancreatitis, I have done Whipple selection, I have done total pancreatitis and so on. It comes from my heart actually. It is not so. If you ask me electrolyte topic to take class, I'll need 2 days time to prepare, because I can't recollect those things, even though I manage patients. So difficult thing, they make a note of it. Previous day read only difficult thing. It is not possible to read entire surgery previous day, mug it up and reproduce in the exam. Don't ever mug the surgery. Surgery is not a muggable subject. It is a science. It is not, it is science. It is science. It is all or none. It is like mathematics, whether you know or don't know. If you don't know, you can't write a single word about surgery. You can't predict. Whereas remember, I'm not against medicine. Medicine is a combination of physiology, pathology, and pharmacology. If you know these 3, medicine comes there. Subject medicine comes there. Whereas surgery is a different art. It's a different system. This different calculation it is. You need to know everything about it. If you don't know, you can't write. It's a very specific subject actually. It is answer to the point. We don't, as a assessment, since last 30 years I'm the examiner. When I assess, I immediately know what wrong they have written. It's very easy to understand what wrong they have written. So write very specific points. Surgery is not very vast. It is a very specific subject. But you have to know. If you don't know, we can't write. We can't just predict and write. Understood? That is what I have to prepare in different way. Prepare previous day what you want to go to read. Difficult thing you read previous day, because that may be asked as a question. So that is the point you have to remember. So accordingly, you have to prepare like that. So that is then theory, clinical, of course, long case, short case. In surgery, long cases are very easy. So hernia, varicose vein, vascular disease, mass abdomen, breast lump, and thyroid. You are through. And short case, hydrocele, lipoma, and swellings, ulcer, neck swelling, oral ulcer. You are through. That is easier. Short case to it only revolve all these things. Then of course X-rays and instruments, common instruments which you see in the OT, that is sufficient to actually. Practical things are quite easier, but only theory, it's a voluminous subject actually. Surgery is so vast actually. And remember, surgery is easy to understand. It's very much more easier to forget. You forget more than what you understand. Today you read and understood everything. Tomorrow you have something, you are totally blank. You don't remember. It's very, very difficult to recollect subject. That's why I still read subject surgery, because I know I forget very easily. That is the point. Surgery is very easy to forget, remember. Even skill you forget if you don't operate. There are many non-operating surgeons. Then they don't have skill. That is the thing. That's probably answers your
Yeah,
in
sir.
brief about
Those were
questions.
just precious words. Thank you so much, sir. That was just an amazing Q&A session. So, sir, can we proceed further with vote of thanks? Am I audible?
Yes,
Yes, please.
Okay. So, sir, I, Shreyas Virwani, on behalf of Squad Medicine and Research and Organizing Committee of Med-Invade 2021, would like to extend my heartfelt gratitude to our honorable speaker, Dr. Sriram Bhat, sir, for taking out from his busy schedule to enlighten us all and answer the questions and queries of all the delegates which were put forward. It was truly great experience learning from you, sir. I would also like to thank our lovely delegates for tuning in for the session. Hope to see you all in our last few successive sessions too. Thank you so much,
Thank
sir.
you. Thank you, Shreyas. Thank you, everybody. Thank you.